Okay, good morning, good afternoon, good evening. This is Dr. Garais, MED210, Anatomy and Physiology 2. This is a video lecture for week 5. Week 5, typically, you have a midterm, so I don't know, I cut you guys a break, but really shouldn't have. We really should have had a lecture right after the exam, but so be it. Decisions were made. So, Chapter 11 in your ebook, we're going over the muscular system. And right off the bat, you already know what it is. Without muscles, you don't have movement. And without muscles, you don't have stability. So let's look at Chapter 11 in our open stacks. I'm going to go all the way here. Okay, let me move this. So the way your muscles work is that all they do is contract. Your brain is connected to a nerve, which is connected to a muscle. Your brain sends a little bit of electricity called an action potential to your muscle, and it tells your muscle to get smaller. So how do you move around if everything can get smaller? Well, because there's going to be some muscles that are going to be doing work, and that's an agonist. And there are some muscles that you're going to have to relax, and that will be the antagonist. And then when you want to move in the other direction, the antagonist is going to contract, and then the agonist is going to relax. And so that there's a balance, there's a give and take. And we know this exists if any of you ever been hit by a taser. And forgive me if you've already heard this story already, but I always talk about this story because years ago, in the state of New York, there used to be a law when I used to live up there. There used to be a law that, in order for you to buy, a quality taser or a taser, I was at a gun show in upstate New York. You have to go through this little education session, which culminated in getting tased. Now, when you look at a taser, it just throws a whole bunch of unorganized electricity into your body, and it forces both the agonist and the antagonist to contract. Everything contracts, and just like a seizure, which is unorganized electrical activity, everything is going to contract. And then what happens? You guys seen the videos. They become stiff as a board, and then you can't control what comes out of your mouth, and then you fall down. And it's, in theory, it's supposed to be a non-lethal way of getting someone who's violent down to the ground. But for us, you could see it pathologically and physiologically that that's how pathology works and how normal works. So in order for me to move my arm, there's going to be one side that's the agonist, right? That's going to be doing some work or contracting. And there's going to be another side that has to relax, okay? We're also going to be talking about what a muscle actually is, what it's made out of microscopically. And of course, identification of skeletal muscles is going to be a big thing for your final examination and laboratory. And we're also going to be talking about these two terms, origins and insertions, because for future training and even future for this particular class, you're going to be asked to memorize all the origins and insertions of all skeletal muscles, or at least the highlighted ones. But for now, we're going to just know and understand what an origin is and what is an insertion part of the muscle. So let's begin. So you look at here, okay? In order for you to pick up this glass, you have to have an agonist or a prime mover. So in this case, flexion of the arm, right? Which is, when you flex your arm, this is going to go up, and the angle here on your elbow is going to decrease. So in order for that to happen, your biceps brachii right here, right? That has to shorten or contract, okay? And that is the agonist, and that is the prime mover in the flexion of your arm. Now, you also have the brachioradialis, which is right here, and if you're at home, playing along at home, flex your arm, and then feel your forearm right around here. You'll notice that tightening it up as well. So that's a synergist. A synergist is a muscle that syn is the prefix that means the same. So it's doing the same thing. It's contracting as well, and it's helping. Something that's a synergist is helping the prime mover or the agonist. So these two things are all contracting and moving. Now, your antagonist, see if there's no, there's not a picture of it. Well, it would be back here, and that's your triceps. Your triceps will be relaxing during flexion. So a good question would be, in flexion of your arm, which would be the prime mover or the agonist? And that would be your biceps brachii. He goes, what's the brachioradialis? Well, it's a synergist that helps the biceps brachii perform flexion. And what is the antagonist? It's the muscle behind here that relaxes, and that's your triceps brachii. And we call it biceps, bi, because there's two heads. Sep means head, and the triceps has 3. Okay? So you could see now how every movement has to have a pair. There has to be an agonist, and there has to be an antagonist. And the classic is the relationship with the biceps brachii and the triceps brachii, resulting in the flexion of your arm. And when you flex your arm, this angle here of your elbow decreases. Okay. Now, learning all of these muscles, you need to know terminology. Okay, and well, I'm going to skip to this part. So, well, actually, I'm just going to give you a little hint. So, for example, you see this? This is a circular muscle. So, what's circular in medical terminology? And that's an orb. So, you have your orbicularis oris. You also have circular muscles on your eyes, and that's your orbicularis oculi. You also have other muscles that look like a shape. Well, this is circular. Well, this looks like a triangle. Use your imagination a little bit. And the Greek symbol that's a triangle is a delta. So this is your deltoid. And you also have certain muscles that go straight. And that's the term rectus. So your rectus femoris is the straight muscle that's where? Covering your femur, or the largest bone in your body, which is right here. And we already known that we can also name muscles based on how many heads or bellies that they have. So for example, your biceps brachii has 2, triceps brachii has 3, your quadriceps here in your thigh has 4. Now, here's a wonderful identification page. If you do not think that this will not be on your exam, guess again. I could easily take this or any other picture and then do what? A, B, C, D, E, F, G, identify everything. So let's look at how do I make this thing bigger? I want to make it bigger. Yeah, there you go. So let's look at from top to bottom for this example. And we already know the deltoid here is your shoulder. Your occipital frontalis. So your occiput is in the back of your head, and the front part of your skull is called your frontal bone. So this right here, this muscle stretches from the front to the back, and that's called the occipital frontalis. Sternocleidomastoid. It's a muscle here in your neck that helps turn your neck left and right. It's connected to your sternum. your clavicle, which is right here, and the mastoid process in your skull, hence the term sternocleidomastoid. Trapezius, there's a better view on when you're looking at the person's back, but also you may have heard it, these are your traps, right? Or your trapezius. And it looks like a shape. Looks like that. And that's your trapezoid. You also have a rhomboidus, which also looks like a shape. Okay? A rhomboid is, you take like a rectangle like this and you squish it. And that's what's called your rhomboid muscle. Let's go back. Pectoralis major, pectoralis minor. Your pectoralis means your chest. You have your major muscle here. And every time you see minor, it's a more deeper, smaller set of muscles. You have your serratus. A better view is here. And it's called your serratus because it looks like a bunch of little knives, like a serrated knife. Rectus abdominis. We already just learned the word rectus means straight. So what are the straight muscles, or your 8-pack here, or 6-pack, depending on what you're looking at, in your abdomen? They're running straight up and down, hence the term rectus, and that's your rectus abdominis. Biceps brachii, we already saw, your brachioradialis, which is from your radial nerve on your thumb side, and your brachium, which is your upper arm. Your brachialis is on the side, medial side of your biceps brachii. And it makes sense. Brachii, upper arm. Brachioradialis connects the upper arm to your forearm. Anytime you have the words flexor, that means they're anterior muscles that will do what? Flex. So we already know that flexion is decrease of the angle. So when you flex your fingers, that means you're closing your hand. And on the other side, you're going to have extensors, which will be the antagonist, depending on what you want to move, right? And that will be extensor carpi radialis. Tensor fasciae latae, lata, lateral, it's on the side. It provides tension in your legs, so it helps you stand and move and whatnot, right? And I know it's got to be the muscle on the side because this lateral. Iliopsoas, your ilium bone is here. So it's connected to there. Gracilis, I don't know. I remember it as, I don't know, graceful. I don't know why. I always think of a ballerina or somebody dancing and they need that muscle. Again, whatever you need to remember things. Sartorius is this long strap muscle here that runs diagonally across your femur. Your rectus femoris, we already went over that. Over your femur, straight muscle. Vastus medialis, it's on the medium side and it's part of your quadriceps. And vastus means what? It's big. And of course, if you have a vastus medialis, another part of your quadriceps is your vastus lateralis. This is the part of the occipital frontalis. Remember, it goes all the way from the front to the back. And here's your occiput. Now, what's an aponeurosis? Aponeurosis is like connective tissue that connects, like ligaments. It connects muscle to muscle. Which are the levator scapulae? Of course, what does an elevator do? Brings things up. This muscle helps you move your scapulae or your shoulder blades up. Supraspinatus, which is part of your rotator cuff, hence the word spin, rotating. Supra, above. Infraspinatus and your teres minor, right? Those all make up your rotator cuff. If anyone's a baseball or football fan, quarterbacks and pitchers, these are the muscles that if they overwork, their pitching arm or their throwing arm, these are the muscles that'll go out. Let's see. What else? You also have biceps femoris, and those are the two sets of muscles on your femur or your thigh here. Remember, femur is the bone, and this is your thigh. Soleus. Now, the gastrocnemius, which they cut here, that's like the big. Now, gastro means stomach, so it's not really a stomach. Oh boy, I gotta hold on. Okay, I'm back. Sorry about that. Okay, so if we look at, and this is more for future reference and also to, what's the best word, to remind you of the importance of your medical terminology. Abductor versus adductor, if you remember your chapter 2 from your medical terminology. When you start looking at these words, abductor are muscles that move away from the, help your body move away from the midline. Adductors are things that help things move towards your midline, just like the flexor and extensor. So now you know what flexion is. The exact opposite is extension. You have abduction, which is moving your arms and your legs away from the midline, and you have adductors, which help move your body parts, particularly your arms and your legs, towards your midline. Okay. So if you look at this, they're all Latin / medical terminology terms that you should know that can help you with identifying. But the best bet for now is everyone loves a picture and everyone loves a diagram. So we just went over this diagram. So go over this diagram, know and understand this diagram, and there'll be more coming. Okay, so let's look at the face. We already mentioned circular muscles, which is the orbicularis oris. Orb, meaning circular, oris, your mouth. You also have your orbicularis oculi. Oculi, meaning plural because there's more than one. There's two of them here. Occipital frontalis, or if you just want to talk about this front part, it's called the frontalis, and the back part is the occipitalis. But actually, it's one big thing that's all connected, and it's all connected here. You see this occipital portion of the occipital frontalis. It's connected by your epicranial aponeuroses. And look at the term epi, on top of what? Your cranium. And an aponeurosis is something that connects two muscles together. Corrugator supercilii. Now, something that's corrugated is something that's wrinkled, and super is meaning above. So it's the muscles that are up here that give your wrinkle lines. Okay. Your buccinator, which is here, along with your masseter, which is here, they help. They're not only muscles of facial expression, they also kind of help in chewing, also known as mastication. Okay. Buccinator is more in the inside, right? And then your masseter is there. Yeah. Okay. So you can see what they do. They have the movements deal with facial expression. Now, let's talk about the difference between origin and insertion. Now, for future training, you're going to have to know this whole thing. Okay, target of motion, where it is. But for now, this picture is good. And for now, knowing and understanding that everything in this picture are muscles of facial expression. So if, remember we talked about how your brain gets connected to a wire, and the wire, which is a nerve, then gets connected to a muscle. And in the beginning, the name of this chapter is movement and stabilization. So your face is your face because of your brain's signal to to that nerve to create that face. Now, we all have seen what happens when our patient has facial paralysis secondary to a stroke. So let's say they had a stroke here on the right part of their brain, and it's going to start manifesting in ptosis, or drooping of the face, especially the eyes and the lips on the left side. And it's because the signal from the brain to these facial muscles is no longer intact. And that's actually one of the main criteria, diagnostic criteria, when you look at someone suspected of having a stroke. If they have any facial, manifestations in their face, any changes in their face. So, for example, one of your cranial nerves is your facial nerve. If that thing gets cut, what will happen? You're going to have drooping of these muscles, because there won't be any signal to your muscles that, hey, you should be contracting just a little bit to organize your face. Here's your muscles of your eye, okay? And they're both of your eyes are connected. And so that's why when you look to the left, both of your eyes have to look left. And we're going to be talking more about that in the end chapters when we talk about special senses. But for right now, all you need to know is the different kind of muscles. So let's say this is the right eye of our patient. So our patient has another eye here. If you want to move the pupil or the eyeball to gaze to your patient's right or to the side, that's your lateral rectus. Rectus meaning the straight muscle. Later meaning to the side. Okay, your medial rectus, right? Once that shortens, it's going to move your gaze for your right eye to your left. And you could see how the medial rectus and the lateral rectus, they're antagonistic towards each other. So if the lateral rectus is shortening or contracting, the medial rectus has to relax so that the eyeball can move this way. You have superior obliques, which make the eyeball go up and outward. And you have superior rectus that makes your eyeball go up and inward. And if both of them together, right, your superior rectus and superior oblique pull, your eyes will go straight up. And it's the same thing for your inferior rectus and your inferior oblique. And this is how I remember it. Oblique is like diagonal. So what's the worst I could do to you? I could ask you a question. Let's focus on the right eye. I could ask about the left eye as well. But let's focus on the right eye. My patient wants to look to the right to cheat on an exam. Which of the following structures would contract to make my patient look directly to their right? And on the right eye would be the lateral rectus. My patient wants to move up, look straight up to the ceiling. Is it A, superior oblique, B, superior rectus, C, both, D, neither? And of course it will be what? Both. And the same can be done for here. And all these muscles are controlled by your cranial nerves 3, 4, and 5. Or is it 3, 4, and 6, I believe? And that's the reason why when they do a neurologic test, or they want to check your eyes, and they want to check to see if your eyes are both moving in the same direction and if they both can follow a pen light. Okay, because if these muscles are working, that means the nerve should be working as well. And that also means that part of the brain should be working as well. Because remember, it's the brain connected to a nerve, connected to a muscle. And the only thing really that the muscle does is contract. But we have antagonistic and agonistic muscles. If the agonist or the primary mover is contracting, then the antagonist has to be relaxing, and vice versa. Here's some other, we already mentioned the masseter, and I already showed you that in the other one. Here's another muscle in your head that's called your temporalis, and it's covering your temporal bone of your, and here are your pterygoids, which also deal with chewing. So masseter, and the pterygoids, your lateral medial. Looks like a nice all of the above question. Okay. Muscles of your tongue. Okay. You see there? Nice to know. But how do I know it's tongue? See that that root word, glossus, glossal? So you have your hypoglossus, styloglossus, genioglossus. Don't really have to memorize it. The second you see glossus, you're like, oh, that's tongue, right? I believe it's cranial nerve 12. You mess that up, you won't be able to move your tongue right. And that's also one of the several reasons why when the doctor asks, can you stick out your tongue and say, I'm not only looking at your throat, I'm looking at to see if your tongue is midline. If not, that might be a brain problem. Here's some muscles in the neck. Nice to know. Here's some of the muscles that we mentioned earlier: sternocleidomastoid, levator scapulae, your trapezius. Remember your traps? It kind of looks like gotta use your imagination a little, like a trapezoid. You know, like this line here, line here, line here, line here. Kind of looks like a trapezoid. Sometimes you gotta use your imagination a bit. And see, only look at, just focus on the pictures that I mentioned and, what's going on here? Only the pictures that I mentioned and, you don't really have to know completely these charts, but they're nice though. Let's look at what's important here. Nice to know the muscles of your back. Again, I'm focusing on, really high yield topics and must know. Here are must knows: your pectoralis major, your lats or your latissimus dorsi. Something that has great latitude is wide, right? So dorsi means back or your dorsum. Here's your serratus, because it looks like, a serrated like bread knife, okay? Of course, your rectus abdominis. And you have muscles that go diagonal. So those are your external obliques. And on the inside, you're going to have another set of muscles that are going kind of like in the opposite direction. And those are your internal obliques. Nice to know your abdominal muscles of your hip. Diaphragm, very important. It is that thin muscle. Where is they going to show it? And here are your intercostal muscles. So your intercostal muscles and your diaphragm, which is the thin muscle that separates your thoracic cavity from your abdominal cavity. Those are the two main muscles for breathing. So if the nerve that connects to those muscles goes down or the muscles themselves have a problem, you're going to have a real hard problem breathing. Here's another thing I want you to notice about another type of muscle. It's a circular muscle. And a classic example is your anus. You can see it looks like a kind of like a purse string. Well, that's all that those muscles are, is like a circular muscle that acts like a doorway. Another such sphincter is your pyloric sphincter at the opening, first part of your duodenum, your small intestine, and also in the fundic portion of your stomach that connects directly to the esophagus. That's your upper esophageal sphincter, also known as your cardiac sphincter. All there is just what? It's a circular muscle that puckers up and closes up so that it keeps contents where it needs to be, albeit temporarily. Doesn't keep it in there forever. Nice to know. Here's another view of your latissimus dorsi, another view of that deltoid triangle shape. Here's a little bit better view of your rotator cuff muscles, your supraspinatus, teres minor, and where is it? Infraspinatus. And remember, Supra, above, infra, within, and goes, and if you have a teres major, which is a larger muscle, you also have a teres minor. And all of these put together form your rotator cuff muscles. And the acronym is SITS, supraspinatus, infraspinatus, teres minor, and your subscapularis, which is underneath all of that. Okay, so now that when you watch ESPN, and then when you hear somebody go, oh, this pitcher or that quarterback has a rotator cuff injury and will be out the season, now you know exactly where. And it makes sense. This is part of your shoulder girdle. And your shoulder, if any of you ever hurt your shoulder or your collarbone, can't move your arm very well. So if this gets hurt or the collarbone right here gets hurt, you won't be able to move your arm very well. Biceps brachii, triceps is on the posterior portion. We've already talked about that. A pronator is a muscle that turns your arm so that you can either put your palm on top of the table or the back of your hand on top of the table, and that's called pronation. You could do that. And if you're not quite sure of all the different kinds of movements like abduction, adduction, pronation, supination, look it up again, chapter 2 of your medical terminology, or just Google it, YouTube it. I've been studying Photoshop and Adobe Premiere, and it's all YouTube videos. I told you the guys the story of how, and I always say it's like last year, but it must have been like 6-7 years ago. I repaired my toilet just by watching YouTube videos. Let's look at other pics. Here's some stuff with the hands. Now, if you see the word digiti, that means it's what? It's your digits, okay? If you see something like polesis, think your thumb. Now, when we're looking at this, like let's say this is the thumb and this is the pinky. Well, we can't really see that. The way we, well, you know, I shouldn't be talking about that because that's bones, and we're going to be talking about bones next, probably in week 6 lecture. Okay. Interossei means in between the bones. That makes sense. If I have palmar interossei, that means it's on the palm side. If I have dorsal, that means I have it on the back of my hand. So a lot of medical terminology skill sets is gonna help you on this exam. We already mentioned the tensor fasciae latae, sartorius, right? Now, adductor longus and the gracilis. Think about it. If I want to pull my leg, and this is my patient's right leg, if I want to pull my leg towards midline to perform adduction, it has to be a muscle where? On the inside of my thigh. So my abductor muscles have to be on the what? Outside. As you can see here. Oh no, those are adductors as well. Where's an abductor? No, this is the posterior view. Okay. Now, how I always remember this, gracilis, remember the most inside, this is my patient's right leg, and the view is from the dorsum or from the posterior. This is how I remember these 3 muscles. Gracilis, because that's the graceful one, that's one all on the inside, then semimembranosus, and then semitendinosus, and then I have the biceps femoris, right? And then I remember like a story and all like in a row. Now, your gluteal muscles, here's your medius and here's your minimus. And the big part, you know, of your buttocks, that's your gluteus maximus. All 3 of these, they're very, very important in walking and standing upright. If you've ever had a cramp in your butt, maybe by sitting too long, and the proper term for butt is buttocks. If you had a gluteal pull, it's painful to stand up, painful to sit down, painful to take to walk. And do you notice what I'm doing? I'm focusing on pictures because it's hard to memorize things this way. And I'm not saying to memorize things this way, but pictures are worth 1,000 words. And they're much easier to memorize. Okay, nice to know about your lower leg, but again, for future training, and eventually you're going to have to learn all of these. Foot. Oh, remember we said pollicis, we think thumb? Well, hallux, I want you to think big toe. Okay? Let's see. Okay. And that's the chapter 11. Hold up. You know, this how do I do this? Okay. So let's go over. And so if it's a muscular picture that we went over, that's fair game. And if I can find a nice blank you guys can practice on, but you guys can look it up. Google has a lot of neat things. Chapter 11, muscular system, role of ATP. So the structure of the muscular system. So you now know all the parts. Physiology of movement and its terms: antagonist, agonist, synergist. Now we have to go over how muscles actually shorten and how they actually contract. We know that it starts off in the brain. There's an action potential or some sort of signal that runs through a nerve, and then it tells the muscle to get shorter. So let's now go back to OpenStax. Where's my OpenStax? To my table of contents. And we're going to go over here the muscle tissue. So what does it actually look like? What does the muscle look like? So this is what muscle looks like. There's 3 types. Okay, so A is the skeletal muscle. You see how it's kind of have stripes? And that's why they call it striated. Skeletal muscle is voluntary. That means you can control it. So when I want to type something, I think about it, and then I type it. Now, these 2 other muscles, B, which is smooth muscle, you see they don't have these like major stripes in it. And that's why they call it smooth. And here is the cardiac muscle. And let's see if you can see the T-tubules or transverse tubules. Here's one of them here. They're hard to see. But these 2, B and C, your smooth muscle, also known as visceral muscle. Smooth muscle cannot be controlled. Okay, it's part of your autonomic nervous system. So when you swallow, I don't know, a cheeseburger, I'm craving for cheeseburgers again. You swallow a cheeseburger, once it starts going down, you can't stop it, right? And that's part of your smooth muscle or your visceral muscle. It lines your entire GI system and all your other things in all your internal organs. Now, the third one is cardiac muscle. And the neat thing about cardiac muscle is that it beats, it contracts on its own. And when you put 2 muscle cells together, it forms what they call a syncytium. Let's spell that word out. And syn means the same. S-Y-N means the same, so syncytium. So that means, make this bigger. Oh boy, that's not a good sign when my Mac is a little bit on the slow side. And I wish there's a way, maybe I could put this on the side. A syncytium, syn meaning the same. It means that when two cells bump into each other, especially contractile cells like cardiac cells, if they're both beating at different times, once they kind of come in contact with each other, they start beating together rhythmically the same. And that's what's the neat thing. So know the differences between striated, voluntary muscle, smooth, and your cardiac. Okay. Now, all of them require calcium. And we already talked about, I believe in Anatomy and Physiology 1, if we remember when we talked about the heart, sodium and calcium were kind of like the initiators and the jump starters for the electrical signal for the heart. And it's also the same thing for muscles. Another thing that muscles also need, they need fuel. And the fuel that they require is ATP, or adenosine triphosphate. So we already now know from our Anatomy and Physiology 1 that we get ATP from oxygen and glucose. That's why the two things you need when you go lifting is you need fuel in your belly, or you need fuel in your system, right? And you need to breathe oxygen. And I've always told anecdotal stupid stories about, you know, how some dudes and dudettes, well, it's more dudes. I've never seen a dudette or a person who's female lift and pass out, but I've seen dozens of dudes do that because they're not breathing. Because if you really, really, really push and you're not getting oxygen into the system, it's all going to shut down. Okay. So what's a requirement? ATP. What is the electrolyte that's going to boost the signal to contract? And it's calcium. And we're going to show you why in a second. Next, please. So when we look at a skeletal muscle, it's made out of a whole bunch of fibers, right? Protein fibers that are what? They're wrapped around and around and around. And as we know, like, you know, when you build a big, heavy, strong rope, it's made up of all these little fibers. Take a good look at like a big rope. If you've ever seen like a big rope, like maybe even the rope that you climbed on when you were in high school and stuff like that, it's made up of all these little fibers. So you got all these little fibers together, and you'll see there's going to be, see this little red, that's an artery, a little blue, there's a vein. There should be a little yellow in there. Oh, here's one, and which is a nerve. So it's innervated with an artery, vein, and nerve. And your muscle fascicle is then covered with a protective covering called your perimysium. Now you get all these fascicles together and you wrap them all up, and then you got a whole bunch of them, and then you cover that with something called an endomysium. Okay, so you put them all together, it's a bunch of like tiny little strings that get wrapped up all together, and then, you know, and that's what gives it the strength. And you could see here, this is a tendon. There's an aponeurosis, there's a fascia or covering of your entire muscle. And the way to check this out is, check it out when the next time you're eating some chicken or even a steak, right? You'll see it's a whole bunch of fibers. And then you, especially eating a drumstick, you see a whole bunch of fibers that lead into what? The tendon part that's right there, okay? And the smallest thing is your muscle fiber that has all these little myofibrils in it. And the myofibrils are formed by these proteins. So all of these are a bunch of chains of proteins, strings of proteins that we all bundled, kind of like, and to make like this rope or wire that's also innervated with arteries and veins and nerves. So what does that mean? Well, it forms this. Okay, this is the called the sarcomere, or the functional unit of muscle, and you see there's certain zones. Okay, now you can imagine how if this thing's a protein and this thing's a protein, if they all push together, the overall length of this is going to get shorter, and that's our goal. Our goal is to somehow make this all this wire or all this rope that we created to get shorter. And how does it do that? Let's find a video because it'll explain this thing a little bit better. And I think there's a nice video in your Moodle, but I'm going to find the one that I was looking at the other way. Okay, so how does the sarcomere work? 9 years ago, 6 years ago? Well, which is the one that I like? Let's go over this one first and then go over the sarcomere, because I've been talking about how the nerve then connects to the muscle and then tells the muscle how to do stuff. So let's look at this first.
I'm Sarah Oda. I am a senior at Stanford University. I'm currently an architectural design.
Professor Dave here. Let's talk about action potential.
He knows a lot about the science stuff. Professor Dave explains.
We just learned about the structure of muscle, like skeletal muscle, which is what allows you to move your body around. But how exactly does this work? If you decide to lift your arms up in the air, what is happening on the molecular level that produces this motion? It's not magic, it's just a staggering amount of chemistry. So let's dive back down into those muscle fibers and get a closer look. As we recall, any skeletal muscle is made of fascicles, and each fascicle is made of muscle fibers, which are the individual multinucleated muscle cells. From there, we can zoom in farther on one of these myofibrils, which are in turn comprised of myofilaments arranged into sarcomeres. And this is the contractile unit, the one that lets muscles do what they do. Now let's get a closer look at these structures, because this is where all the action happens. Looking at a sarcomere, we can label a few regions. We can see these darker A bands and the lighter I bands, which are aligned and responsible for the striated appearance of skeletal muscle. Within each A band, we can find a lighter region called the H zone, and this H zone is split down the middle by something called the M line, made of a protein called myosin. The I bands are also split down the middle by a region called the Z disc. We can identify an individual sarcomere as being a section from one Z disc to the next, and this is the functional unit of skeletal muscle. If we zoom in even more, we can see the myofilaments that make up these regions. As we discussed previously, the thick filaments contain myosin, and these extend across the A band, connected at the M line. The thin filaments contain actin, extending across the I band and into the A band. There are also elastic filaments made of titin, spanning from the Z discs to the thick filament and then continuing on, acting as the core of the thick filament. Now let's zoom in even further on these two main types of filaments. Myosin is a protein with two globular heads pointing outwards and a long tail, which contributes to the structure of the filament. The heads are the site of all the activity, since there are ATP binding sites, as well as actin binding sites, meaning this is where the thick and thin filaments will interact by making cross bridges. It's important to note the lack of myosin heads in the center of the sarcomere, just as there also are no thin filaments. Speaking of those, as we said, they are made predominantly of actin, and two actin filaments will twist together to form the backbone of the thin filament. Each actin subunit has an active site where myosin can bind, and when a muscle fiber is relaxed, these are blocked by spiraling strands of tropomyosin. There is also troponin, a globular complex of 3 polypeptides, one of which binds to actin, one of which binds to tropomyosin, and one of which binds calcium. Beyond this, we must be aware of the Sarcoplasmic Reticulum, a series of tubules that surround each myofibril. These regulate levels of calcium, which is needed for muscle contraction through storage and release. This structure includes the T-tubules, which sit at each A-band, I-band junction, encircling each sarcomere and helping signals reach every region of the muscle cell. Now that we've examined each structural component, let's describe how everything works using the sliding filament model of contraction. This says that when the nervous system stimulates muscle fibers, the myosin heads on the thick filaments will interact with the binding sites on the actin subunits. These attachments will form and break several times as the thick filaments pull the thin filaments in towards the center of the sarcomere, thus pulling the Z-discs towards the M line. The I bands shorten and the H zone disappears.
Now, right, you have the actin and you have the myosin, and then what they're not really showing here is these things come out and they kind of pull on this. So the overall length gets shortened. And for our purposes, you could see it requires calcium because the calcium binds to these heads. And once the calcium binds to these heads, it makes it have the capability of pulling these other proteins. And that's what shortens it. Now, all these other things, Z-disc, H-zone, all well and good for, for future reference, and you're going to need to know that. But for the exam, now you could, I guess the worst I'll ask you is so which are proteins that are responsible in the myofibril or part of the sarcomere, which is this whole thing right here. And you'll tell me actin, myosin, both, neither. And it's of course both. And he goes, what's required? Calcium. He goes, what's also required? ATP, because it needs energy to for this head to do what? Pull on this so that these things get shorter. And that's when we have an action potential, and that's when we have a signal. And then what happens if there's no more signal? Everyone goes back to their neutral corners and goes back to the default, which is relaxation. Okay, so that I just wanted you to get a better picture of what this is and what does it mean.
The overall effect is that the A bands from adjacent sarcomere.
Okay. So you could now see, now going to this, the neuromuscular junction, you're going to need a nerve, and it's going to have to connect into one of these sarcomeres and the muscle itself. So that's why you have a nerve that has electrical impulses, then will send chemical impulses in the form of neurotransmitters. And one such neurotransmitter is acetylcholine. Acetylcholine will go here and then do what? Give the signal, open up the calcium channels, let's do business, get ATP up and running so this thing can shorten. So you can only imagine if you had a drug like acetylcholinesterase or a drug that blocks this, then my patient will be paralyzed, won't be able to move. Right? Or in the case of myasthenia gravis, there are enzymes that break all this down, and then my patient won't be able to move. So you could see where it requires a nerve and a muscle. The nerve is not only electrical, it's chemical. And the muscle then reacts via chemicals. The chemical that passes from the nerve to the muscle is called a neurotransmitter. Neuro, nerve, transmit, trans means to do what? Go across. Mit, the word transmission means to communicate or to move that signal across. And the classic one for muscles is acetylcholine. So you can only imagine if I had an acetylcholine blocker or something that has the enzyme acetylcholinesterase, I could paralyze somebody. Okay, and you could now see. If you know how normal goes, all you have to do is mess things up. And by the way, we give you such drugs for surgery, because do I want you moving around in surgery? Even even accidentally? No, I do not. So you can see here, right? Thick filament, right? And thin the thin filaments here. And then the binding heads latch onto this, the green, and then it starts pulling. And it's pulling because ATP gave it the energy to go pull. Neuromuscular junction is the thing that I just explained right now, right? You have the nerve connected to this gap. It's called your synapse, right? Or synaptic cleft or synaptic gap. And what goes through there is neurotransmitter. But in order for the neurotransmitter to go, you see this lightning bolt here? That's a nerve impulse. That's electricity, also known as an action potential. Because there's a potential for action to happen. But first, the neurotransmitter has to go through. Can you also see now how performance enhancing drugs can make you go faster and do things chemically? It messes with this. Okay. And looky here. The excitation from the action potential and the neurotransmitter will tell what? Release those calcium. And we release the calcium from T tubules, which by the way, cardiac muscles got tons of them. Right? The ATP gets converted to ADP, and then what happens? Right? And then the muscle, the sarcomere will get shorter. And if all the sarcomeres get shorter, the muscle gets shorter. So what kind of questions could I ask? What's a neurotransmitter? Oh, by the way, this nerve plus muscle is called any nerve that attacks to a skeletal muscle. That's called a motor neuron. So neuron, nerve cell. This is a motor neuron because it's going to make you motor. It's going to make you do something. Also known as, if you recall anatomy and physiology, descending tracts. You can remember that from your last set of lectures. Okay. So it gets from all relaxed here, and then you start pulling, 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 and then it gets shorter. So you could see here. And that's contraction. It requires ATP. See, the ATP gets used up on the myosin head, and then forms ADP, and the phosphorus gets kicked out. Ooh, what just happened there? Okay. ATP, creatine phosphate, ADP with creatine kinase requires ATP energy. And that's why you see all these like muscle heads in the gym, you know, eat all this powder stuff because that's what's in there. And you could see, where do I get it? I got it from my blood glucose and muscle glycogen. Glycogen is the storage form of glucose that gets released. And then we, of course, have aerobic respiration, right? Requires oxygen and lactic acid. That's the byproduct. And that's why when you work out inefficiently or work out too hard, that's when you start have cramping because of the lactic acid. That's why, if let's say you haven't been to the gym in a while and you just run 5 miles because you want to make up for lost time, you're going to have mild lactic acidosis build up in your blood, and it's going to cause that cramping and that muscle cramping and muscle pain. What we already know, glucose plus oxygen equals ATP. Where does it happen? Cellular respiration in mitochondria. Okay, these charts right here, these pictures, beautiful, beautiful pictures for lovely, lovely questions. Let's see. Oh, movement. We already went over this. This gets shorter. So the movement would be flexion. And then the exact opposite would be extension. And if you don't move at all and you try to keep it all in the middle, that's called isotonic contraction. So the iso meaning same, tone, meaning, the tonicity or the tension of your muscle, because you're not going anywhere. These are wonderful exercises in the gym because it helps tone and firm your muscles. And by the way, you gotta have not only a cardiovascular thing going on. It's highly suggested that you also do some light resistance training, and it doesn't have to be weights. It could be those those really nice plastic bands and stuff, like, not plastic, what is it, rubber? Now that motor unit that I was talking about, that motor neuron, that's the nerve plus the plus the muscle. Okay. Now, how do you lift up heavier things? Well, you have to activate more motor units, more nerves, and more muscle fibers. And that's called recruitment. Okay. But there's a certain level at which you can't, you can't get any more strength, and then it'll plateau and it'll go down. Okay. See how it plateaus? And that's called tetany, tetanus, right? And then there's going to be a point where you can't hold it on any longer. Whoop. Try it. Pick up a 1 pound weight, hold it over your head for as long as you can. In a couple of minutes, it's going to start to hurt. Hated that. Hated that. You did that a lot in the core. Make your hold your rifle out. Ugh, awful. Muscle tone, and remember, we all have muscle tone because we're all conscious. But when you become unconscious, can you keep yourself upright? No, you no longer can keep yourself upright. So if you have hypotonia, you probably won't be able to stand very well. Probably won't be able to balance yourself very well. Hypertonia is the exact opposite. It's too much tone. It's too. You could get that in Parkinson's and different types of palsy. What else is good for the exam and stuff? Resistance exercises. Ooh, this dude's jacked. Oh, now we already discussed that you need a constant signal from your brain to your muscle. And if you don't use it, you lose it. So let's say, for example, my patient's in a coma, or my patient has paralysis. What's going to happen over time if they don't do their physical therapy? If your body has this idea, and you can see now why, because it requires ATP, it requires glucose, it requires oxygen, glycogen, muscle glycogen. If these things aren't active, what's going to happen to the muscle over time? It's going to shrink. And it's that adage that I kept on talking about, that in your body, if you don't use it, you lose it, and you get muscle atrophy, and that's really rough. A lot of physical therapy that has to go into that. Just try it. Well, when you, if you get sick and you're just in bed for a couple of days, try running right after. This weekend, I had a really bad gout attack, so I essentially was sitting from Friday to Sunday night. I was essentially on the couch with my elevated feet and on pain meds. Sunday night, the baby fell or something like that, and I fell running up the stairs because my legs couldn't take me to where I needed to go, because there probably was some mild atrophy over 72 hours of me just sitting there on the couch. We talked about the 3 different types of muscle already. Okay. So let's get to that part. I think we're done. I think we're good. So let's go back to see if we hit up all of our objectives. Did we do the structure of the muscular system? Yes. Physiology of movement? Yes. And how muscles contract? Yeah, we did. let's now look at chronic fatigue syndrome. Okay, that's pretty straightforward. And remember, try to get some try getting citations, of course, in the proper citation format from 2020, 2021, because we're in science and we always have to be updated. And the lesson that's due, here's your application assignment. Download the case, Rise and Shine, section 1 through questions 1 through 6, and question 7 through 13. And that should be good enough. All the questions are good. Okay. With that being said, thank you everybody for watching the video or watching my class. And I'll see you on the next class.